Welcome, everybody. I'm very happy to welcome today also Professor Rodrigo Salgado from the Department of Radiology of the Antwerp University Hospital in Belgium. I know Rodrigo since a long time as a very active radiologist in cardiovascular imaging. I also got to know him even better since we met in the executive committee of the European Society of Cardiovascular Radiology. I think he will be one of the upcoming presidents of the society. And he's an expert in cardiovascular imaging. And we are very happy that he will today contribute to our Grand Round series with a topic on CT for TAVR planning. Thank you, Rodrigo, for being with us.
Thank you, Hatem. Thank you, Robert, and thank everyone for joining me today for this lecture. It's actually a great honor to be in the presence of such great people and friends, and I hope that you will enjoy my lecture. So today I'm going to speak about what can CT do for TAVR, what is important prior, but also after the valve implantation. And as everything in science, there are things that we know, but there are also things that we don't know. And we know that there are things that we don't know. And I think nobody put it more confusingly than Donald Rumsfeld, the Secretary of Defense of the United States in 2012, as this famous quote can show you here. So today we are going to do just that. We are going to, at the end of my lecture, filled in these circles with things that we do know and things that we're still looking into and are not sure what to do with it. So at the end, you will learn everything there is to know with regard to practical points of TAVI, but also maybe some future directions that it might go. So let's start at the very beginning, because we have a patient and that patient has a specific problem, and that problem is aortic stenosis. Now, aortic stenosis, as you see here in the illustration, evolves from a normal valve to a severe stenosis, and is the most frequent valvular disease in the Western world. What you maybe don't know is that aortic stenosis is a progressive disease with a very high mortality. A 2-year survival of 50%, meaning that when you have severe clinical symptomatic aortic stenosis, there are some people with metastatic cancer that have even a better prognosis. Luckily, there is a cure, and the standard of care is still, in many parts of the world, surgical valve replacement. Now, the thing is that when you are very old and you have a lot of comorbidity, the surgery is actually quite dangerous for you, and there are many people that can't have that surgery. And as you see here in this graph, when you can't have surgery, you won't survive for very long. So for that segment of people, we need a different solution. Enter TAVI of transcatheter aortic valve implantation or replacement. So what is the principle of aortic valve replacement using a transcatheter valve? It's actually quite straightforward. We're going to position a transcatheter valve in the aortic sinus, mostly using an endovascular way. We're going to deploy that valve using a balloon or using a self-expandable valve. And at the end, this prosthetic valve will have crushed the native aortic valve to the side of the aortic sinus, restoring valvular function. So this is the principle of any transcatheter aortic valve replacement. For the moment, there are two main valves on the market that are used for this procedure. On one side, we have Edward Life Science with the SAPIEN 3 Ultra platform at this moment. This is a balloon expandable valve. And on the other side, we have Medtronic, who publishes the self-expandable Evolut Pro Plus platform. The main difference between these two types of valves is that one is balloon expandable and that the other one is self-expandable. Keep that in mind for the rest of the presentation. Now, we started doing these trials of the first animal model already in 1992. And all these trials that I'm showing you here were done in the initial population, so the patients who are inoperable or are very high surgical risk. But in recent years, we also have seen other trials looking at a different population, patients with an intermediate to low surgical risk. And there is a lot of going on at this moment regarding the benefits of TAVI in this population. But for the moment, the main reason that many people, almost all, will do a TAVI still is for the inoperable or high surgical risk patient. And has TAVI been successful? Yes, it has been quite successful. These are numbers from Germany that you see that there is an increasing number of TAVI procedures and a decreasing number of surgical valve replacement. Also for Germany, older age is the main reason to select TAVI over surgical valve replacement. And when you're older than 80 years old, it's actually the de facto standard of care. And also in hospital, mortality after TAVI is declining as people are gaining more experience. What does this mean? Well, it does mean that TAVI is not going to go away. It's also only going to increase further. And when we look at this publication, gathering data from different sources, we can see that, for example, in the United States, we have 115,000 TAVI candidates a year, about 60,000 TAVI candidates in Europe, meaning 180,000 TAVI candidates a year for the high or inoperable surgical risk. When we add the potential people with low risk, that number rises to 270,000, which means that surgeons and interventional cardiologists, but also radiologists, are going to have a lot of work in the future. Especially when you consider that this transcatheter valve replacement not only is applying to the aortic valve, but also increasingly to the other cardiac valves. So our role as radiologists in the selection and follow-up of this patient is only going to increase further and further. Now, as we are going to talk about TAVI, I think that we have to review some essential anatomy because it's going to explain why it is for us so important to understand what is going on and to make a good report. Now, as everything in nature, it isn't organized in orthogonal planes. As you can see here, the aortic root has a double oblique orientation, meaning it's especially suited for 3D imaging modalities like CT. Looking more in detail to the aortic sinus, and you can see here that the aortic leaflets extend from the sinotubular junction to the LVOT crossing. You can see that the cross-sectional morphology of the aortic sinus varies depending on the level that you are at. When you are at the level of the sinotubular junction, well, it's mostly a circle that you can see. But when you go down, for example, you see that this circle becomes more triangular, more clover-leaf shaped. And when we are at the basal attachment plane of the leaflet, the so-called aortic annulus, you see that very often, in my experience, nearly always, it isn't a circle, but it's an ellipsoid shape, an oval shape. And this has, of course, implications. Looking more in detail, on the CT image, you can see here at the level of the sinotubular junction, you can see that the cross-sectional morphology is circular. But as we go down, and you can see here the thickened and calcified aortic valve leaflets, you can see that the shape is becoming more clover-leaf shaped, more triangular. And when we go even down, you will see that it becomes more and more an oval, an ellipse. You can see here the most basal attachments of the aortic leaflet planes. You can still see them. The moment that you can't see them anymore, that is your aortic annulus. And again, the aortic annulus is not a real anatomical structure. It's a virtual ring connecting the most basal insertion points of the aortic leaflets. Now, why is that so important that we know this anatomy so well? Because, for example, when you do an echocardiography, the cardiologist is always going to report only one diameter. So what he thinks that is the most largest diameter of this aortic annulus. But it's difficult to correlate that with CT because we have an oval shape and we have a long and a short axis. So beware when comparing measurements from one modality to another. So, and this brings us to the point why we as radiologists make a very nice contribution in selecting the best patient for the base valve. Because we are trying to put a valve, a transcatheter valve, which is circular by design, in an aortic annulus that is mostly non-circular. So how do we fit these two together? How do we make this more compatible? Now, looking, for example, at the offering of Medtronic, you see that they have different transcatheter valves for different sizes of the aortic annulus. The size of the valve ranges from 23 to 34 millimeters, and it applies to an aortic annulus between 80 and 30 millimeters. So meaning when you have a patient who has an annulus between this range, it can receive this type of valve. But how do we rhyme this? Because you said, well, it's not a circle. We have an oval with not only one, but several dimensions. How do we correlate this to a specific valve? When we do a TAVI patients, these are at least the minimum dimensions that we give. We give the cross-sectional short and long axis, but we also give the area and the perimeter of the aortic annulus. We do this, of course, using ECG gating, and systolic measurements are preferred because in that cardiac phase, the aortic annulus is supposed to be the largest. Now, what you also have to realize is that there is difference between self-expandable and balloon expandable valve. The self-expandable valve will expand until it encounters a resistance. So after deployment, it will assume the same oval shape at the level of the aortic annulus as the annulus itself. The balloon expandable valve will use the radial force of the balloon to force its circular design on the aortic annulus. So at the end, we also will have a circular deployment. In order to have sufficient sealing, these valves have some degree of oversizing, meaning that for a self-expandable valve, we aim at 10 to 25% of circumferential oversizing, while for a balloon expandable valve, we aim at about 10% of area oversizing. And this is important because one of the questions that I get asked from time to time is, how do we actually help selecting the best kind of valve? What are these measurements bringing to the table? So I would like to solve you in 2 slides the following case. We have a patient with an echocardiography measured annular diameter of 23, and you see here the CT-derived measurements also in green. So based on the CT measurements, you would either go for the Evolut Pro 26 millimeters, who has a range of 20 to 23 millimeters for the annulus, or you would go for the Evolut Pro Plus with 29 millimeters with a different range, or you'll say it does not matter because both valves apply to the same annular diameter, or you say I need more data. Now, how do we solve this? So we stated 23 millimeters of diameters on ultrasound. When you look at the diameter oversizing, you see that the right valve has more diameter oversizing than the left one. But remember, we're not looking for diameter oversizing. This is a self-expandable valve. We're looking at perimeter oversizing. That's the parameter that we want to follow. So we measured with CT 70 millimeters of perimeter, meaning that for the left valve, we only have 3% of oversizing, but for the right valve, we have 16% of oversizing, meaning for this particular patient, this valve will fit him the best with the least possible amount of complications. And this is exactly how CT helps the surgeon and the interventional cardiovascular choose the best size of valve for that particular patient. So anatomy, I think that we can state that the annulus is indeed a vertebral structure, but it's not a circle, it's oval. 3D imaging is key, and CT brings everything to the table regarding dimensions to look for the best possible fit of a specific size of valve for that particular patient. Most of the patients that come to radiology already have the diagnosis of aortic valve stenosis, which that is also an ultrasound diagnosis. But with CT, we are very good at looking at calcifications of the aortic valve. And there is one instance where these calcifications of the aortic valve leaflets come in very handy, and that is for the specific clinical situation where you have a patient with severe aortic stenosis, but has a low flow, low gradient. What does it mean? Now, I would like to use this brilliant illustration from Ricardo Budden. This is the normal situation. When you have a stenosis, your flow velocity increases, as you can see here. But when you have already a low flow, because, for example, you have low ventricular output and you have a stenosis, you can see here that the flow velocity does not increase that much. So even when you have severe aortic valve stenosis, there is still low flow, low gradient. And this is a very problematic thing because with ultrasound, we cannot prove that this patient has severe aortic valve stenosis. But it has been shown if you perform a simple Agatston score of the leaflet calcifications and you have at least 3000 Agatston score for men and 1600 for women, that the chances that you are severe aortic stenosis are very likely, independent, completely independent of your ultrasound diagnosis. And this is, of course, very helpful in these difficult cases. Why is there a difference between men and women? Well, it appears that women have more a larger component of fibrosis, meaning that they can have severe valvular dysfunction, severe valvular stenosis, with less calcifications than men. Or conversely, when women have the same amount of calcification than men, they have probably more severe aortic valve dysfunction because of their larger fibrotic component. Also very important to look for is bicuspid valve, because of course, bicuspid valve, they degenerate quicker and they will often lead more often to valvular dysfunction and aortic valve stenosis. We know that when we have a bicuspid aortic valve, that there is a greater chance that after the procedure, the patient will end up with a permanent pacemaker implantation for conduction disturbances, but also when the valve is heavily calcified, it's very difficult to determine valve cuspidity. But special attention anyhow for bicuspid valves. So regarding the diagnosis, it is clear it is not a radiological diagnosis, it's an ultrasound diagnosis. But when you have low flow, low gradient situations, calcium quantifications is indeed problem solving. And take especially notice when you think that you have a bicuspid valve, certainly mention that in your report. Any other important points before the procedure is, of course, when you deploy the transcatheter aortic valve, calcifications in the leaflet get displaced and they might obstruct the coronary ostia. It's a rare complication that never happens until it does. The rule of thumb is that the height of your aortic sinus until the ostia of your coronaries should be at least 1 centimeter. But calcium is a very particular component of the aortic sinus. It can also inhibit correct deployment of your transcatheter valve, and it can also appear on a subvalvular level. So I think that the distribution of calcium is very important when looking for a good success rate, but it also helps you in fixating the transcatheter aortic valve. And I always mention explicitly when we have a patient with aortic valve stenosis who has little calcifications, because then they should take extra care for the potential migration of the valve after implantation. So also what is important, we can provide with CT the exact angulation of the tube so that the 3 insertion points of the 3 different leaflets appear on the same plane. It will save your intervention cardiologist a lot of time to get the correct angulation. So we have to get there, of course, to the aortic sinus. We have to go somewhere, And the preferred route still is using an endovascular approach, mostly through the groin, but you can also go through the subclavian or the carotid artery. There is also a minimal invasive approach with the mini sternotomy when you go transaortic, and the balloon expandable valves, they can also be inserted through the apex of your left ventricle, which in my opinion puts the term minimal invasive a bit more into perspective. So we need, of course, need to be aware that we can get to the aortic sinus. If you have severe iliac stenosis, then that path is a no-go. Also, when you have, for example, extensive thrombus in the apex, or when you have extensive wall calcification in the aortic, in your ascending aorta, it of course limits your options for access. So other findings, should we look at the coronary artery systematically? I think it depends. I always do that, but most of these patients have extensive calcifications, but you can rule out on occasion significant coronary artery disease. It saves the patient one contrast injection more for conventional angiography. But I think more important, as we're looking at older patients, what do you do with this? What do you see with this suspect lung nodule in an 86 or 87-year-old patient? This is for the heart team, because often the prognosis of aortic stenosis will be worse than this potential malignant disease. So a multidisciplinary approach is necessary, but this does not mean that the patient will not receive the transcatheter valve. So regarding access route, it's important that you check, is there any obstruction along the way, because it may influence your approach and also the type of valve that you're going to use. But luckily, minimal luminal sizes are steadily decreasing and access points are expanding. In Antwerp, if we can go to the groin, we always use the brachiocephalic approach to the brachiocephalic artery. So concluding before the procedure, what do we use CT for? Annular sizing in access route evaluation, certainly. Evaluation of valve cuspidity, yes, certainly. Agatston score of leaflet classification only when you have a low flow, low gradient situation, not systematically. Coronary artery evaluation, I think it depends on your local expertise, practice, and equipment. And so we come to after the procedure. A few years ago, my lecture would have ended here, because is there a role for CT or MR after the procedure? Then the answer would be no. But this is 2024 and things have changed. So looking at potential complications, I think it's important to have this timeline in your mind, because the most important complication after the procedure is leakage between the transcatheter valve and the wall of the aorta, this so-called paravalvular leakage. Now, paravalvular leakage is an ultrasound diagnosis. It's not a CT and not the, by definition, an MR diagnosis. But we have also thromboembolism. Thrombosis can occur at any time. We have, of course, the risk of having endocarditis. And then finally, and this is a very important point for the future, we have structural valve dysfunction. Now, let's have a closer look. Paravalvular regurgitation, as I said, this is not a CT diagnosis, despite the fact that in cases like this, you can have a very convincing image that shows you apparently a leakage between the transcatheter aortic valve and the wall of the aorta, since you have this extensive calcification that inhibits normal deployment of the valve. But my advice to you, don't make functional conclusions based on solely morphological images. In this case, the calcifications actually also functioned as a kind of buffer, preventing the flow of blood, and these patients did not have a paravalvular leakage on ultrasound. We do CT sometimes when we have, for example, an abnormal ultrasound and we cannot see what is causing that abnormal gradient, like in this patient who had the persistent elevated gradient after the procedure, but you can see here that the transcatheter valve is not correctly positioned. This is, of course, not something that you can see with ultrasound, but you can see it very easily with CT. And this is are the rare instances where we do CT to check for a possible reason of persistent valvular dysfunction after the procedure. Now, can we quantify paravalvular leakage with MR? Yes, we can. This paper from Marseille shows us just that. But I must say, I have never got one single request to do an MR for this indication. Mostly it is solved with ultrasound. However, there is this other thing which is called subclinical leaflet thrombosis. And what is this exactly? It turned out when you are going to scan patients after the procedures who are doing perfectly fine, they have normal ultrasounds, they have no clinical complaints, you will see this leaflet thickening, this abnormal leaflet thickening, and this subclinical thrombus formation that you can see here also on the different images. And also, when you do a functional study with CT, you can see that these valves do not function very well, that they have this reduced leaflet motion and the mentioned subclinical thrombosis. And this is, of course, quite important because it was a striking feature of a paper that appeared in New England already in 2015, that even in patients who have normal or near normal ultrasound results, we could see these really abnormal CT images. Which brings us, of course, to the point, what are we going to do with that? It, especially when considering it's not only in transcatheter valves, but also to a minor degree in surgical valves. And this is important because are we going to treat patients or are we going to treat images? And what are causing is this? This recent paper also indicated that maybe the deformation of the transcatheter valve after deployment, and I already showed you one example with very prominent deformation, might contribute to this subclinical thrombosis. But it is subclinical, so should we treat the patient with more severe anticoagulation just because the images are abnormal? A few years ago, there was no consensus because we didn't have enough evidence, but we are gathering more and more evidence that indeed, when you have this reduced leaflet motion of the subclinical thrombosis, that it is associated with a worse outcome. So, regarding subclinical thrombosis after the procedure, I think that CT, there is no place for systematic screening with CT now. There is no guideline that says you must do so. And for the most important complications, paravalvular leakage is mostly an ultrasound diagnosis, but on occasion, CT can be helpful regarding the position of the valve in a patient who has persistent abnormal ultrasound. Coming to the last point, structural valve deterioration, and this is very important when looking at the future, because remember, we were talking about the very old patient who has severe aortic valve stenosis and has only a few years to live. But what is going to happen when we are going to apply the same technique to the patient who is maybe 50 or 60 years old, who has a larger life expectancy? How are these valves going to behave in 10, 15 years from now? And for detecting of this structural valve degeneration, the most promising results are coming from the combination of CT with nuclear imaging using special tracers that can detect the inflammation in the valve and the subsequent calcification with CT so that we can detect before structural valve degeneration. Now, the problem that we have at this moment regarding the transcatheter valves that we are planting in our original population is that this, of course, very old people, and this is a study from France that after 7 years, only 19% of the people had survived, meaning that it's very difficult to make long-term prediction at this moment. Nevertheless, several trials have indicated that regarding the durability of these transcatheter heart valves, we are quite optimistic that they can be still functioning after 5 to 10 years. But what are we going to do when we have a degenerated aortic valve already in place? How going to solve it if we already had a TAVI? Then one of the solutions is to put another transcatheter heart valve to replace the original transcatheter heart valve. So to have a valve-in-valve situation. And this is, of course, what we already do now for bioprosthetic valves. Here on the left, you see a degenerated bioprosthetic valve in which we restored valvular function by putting a transcatheter valve in place. So this valve-in-valve treatment might become even more important as we extend this technique to younger patients, and eventually we have structural valve degeneration. And of course, technique is not standing still. These are images delivered to me by Professor Budde from Rotterdam. The photon counting CT shows us with extreme detail the different components of a valve-in-valve situation, and also possible thrombus. The movie is not working, sorry. But I think for this specific indication, there is certainly a very good point to make for photon counting CT. Now, last two slides, because until now, we have only talked about the aortic valve itself, how to replace it, how to look for structural valve degeneration, how to eventually cure structural valve degeneration by putting another transcatheter valve. But we have, of course, the myocardium, who has suffered for a long time from the effects of aortic valve stenosis. And we have learned also that the myocardium reacts differently depending, for example, on the presence of pulmonary hypertension, depending on the presence of a metabolic syndrome. It's also, of course, different from men and women. So it's not because you have replaced the aortic valve and restored valvular function that the myocardium said, okay, everything is fine. We have, again, a normal life prognosis. And this is, for example, I think a very exciting field with CT, as we are expanding our application by looking at extracellular volume with CT, that we can detect myocardial abnormalities, also, for example, by doing strain imaging, so that when we have a patient, we can not only deliver the morphology of the aortic sinus, but also have an assessment of the damage that the myocardium already has, which might influence, as this paper insinuates, prognostic information beyond the plain restoring of valvular function. So I would like to finish this circle with the outcome. I think that structural valve degeneration remains a challenge, but we are quite optimistic based on recent trials. And maybe there is a potential for CT and hybrid molecular imaging for the future in trying to detect this degeneration in time in order to prevent further progression. So when to use CT and MR imaging after the procedure in asymptomatic patients? No. In symptomatic patients without an explanation on echocardiography, yes. To detect subclinical thrombosis and reduce leaflet motion, no, but that might change in the future, we will see. And use MR for valvular dysfunction, I would say on a case-by-case basis, but in my experience, it's very rare. But CT for myocardial evaluation, I think this is very promising, but it's still under evaluation. So to conclude, a look at the future, there is a lot of going on in a TAVI patients. This gives you, again, a brief overview of what we have discussed in the last 30 minutes. It's not only about anatomy, it's also about the repercussions on the left ventricle. It's about structural valve degeneration for the future, and it's about treating patients and not necessarily images. So I think we have come to the end of my lecture. I would like to focus once more that the radiologist is not a glorified technologist, but is also a clinician. We are an integral part of the heart team, and we are very happy to contribute to that. I would like to thank you for your attention, and I'm open to any questions that you might have.
Thank you, Rodrigo. This was brilliant. This was a really insightful presentation, I have to say. I really enjoyed it. Excellent. You're an excellent teacher, as always. So that's why we are so happy that you joined our grand rounds. Are there any questions? Are there any questions from the audience? We have participants from around the world, so maybe there are some. There's already one in the chat, so maybe we start with this one. The question is that pacemakers are increasingly implanted after TAVI procedures. Does CT has any chance of predicting this or helping preventing even pacemaker implantations?
No. The thing that we can say at this moment is when you have a bicuspid valve, that you should report it because it increases your chances of having more conduction disturbances after the implantation. And I think that the surgeon and the cardiologist have to be aware of that. I'm not sure if it's going to change their approach. I think that also the manufacturers are aware of this problem. Maybe they're also working on solutions for that. But I didn't think at this moment, besides the fact that we must report that we think that the valve is bicuspid, there is not any more information that we can give regarding the potential problems that may arise. Besides maybe the presence of extensive subvalvular calcifications, which might impinge on the basal septum and increase as such also your risk for conduction disturbances. But again, I would be very careful to make functional prediction based on solely morphological images.
Okay, thank you. Are there any further questions? There's currently no question in the chat.
I have a question.
Maybe Hatem.
Rodrigo, what you didn't mention is the coronary arteries. As we all know, this is a quite open discussion about whether or not to treat coronary artery disease in these patients and to which extent. Is there a role for CT in these patients, coronary CT, and when you anyway do a CT prior to the intervention, or are the chances to have a non-diagnostic images too big? What is your experience?
Well, my experience is that it varies from patient to patient. So I always look at the coronary arteries, and when I'm pretty sure that there is not obstructive disease, I mention it. Why is it important? Because in our hospital, when there is no recent information regarding the coronary status, every patient gets a conventional angiography to look for coronary artery disease. But it also means an additional injection of contrast. So I think that the main reason to look for CT is just to avoid having an additional examination with minor risk, but especially by further decreasing kidney function by additional contrast. So we do look systematically at the coronary arteries, but sometimes, for example, you have extensive calcification, and then it's very difficult in that case to make a firm assessment, okay, this is not obstructive. But I think it works for the negative predictive value, but doesn't work, of course, for the positive predictive value. And I think it also depends on the image quality and of the scanner that you have. We have lucky to have top-of-the-line CT scanners in which we mostly have very good image quality of the coronary arteries. If your image quality is less, or if you have a less performance scanner, then it can be difficult. So I would say, yes, you have to look systematically, but don't expect a conclusive result with every patient.
Yeah, fully agree with this. This matches also our experience. Sometimes it's not possible for many reasons. It's not only the calcium. I would say it's often the quite elderly, old patient with perhaps not so compliant, not hearing very well. You have to shout at him, and many comorbidities at that age, and then overall the image quality can be really critical. But sometimes it works amazingly well to rule out CAD, and then we should do it.
No.
Yeah.
That's correct. And also, a thing I didn't mention is regarding the scanning protocol. In Antwerp, we don't use any medication for TAVI patients because they are frail patients. You don't know what is going to happen. So we don't use the usual beta blockers that we use, for example, for a conventional cardiac CT of the coronary arteries. So as you said, then sometimes you have patients who have atrial fibrillation. Sometimes you have patients who have high heart rates and there is nothing you can do. Now, the fact that we don't give any medication is not universal. I know from centers that do give beta blockers, but I think it depends on the local experience. We we don't have the custom to give beta blockers or any medication to TAVI patients. Maybe we are too careful, but that's just how we are. We like to send the patient live and well back to his room. But I can imagine that there are other people who have good experience giving medication under supervision to lower heart rate, and as you saw, also increase image quality of not only of the valve but also of the coronary arteries.
One additional question, perhaps a more technical one. So when it's about imaging patients with suspicion of a restenosis after TAVR, what protocol do you apply?
Well, we use the same cardiac CT protocol as always, with the modification that we scan for the full heart range, so for complete systolic and diastolic phase, and that we don't use any dose modulation because we want to have the same image quality across the complete heart cycle. So if you use, for example, the standard cardiac CT protocol, where we preference the phase in which we think that we will have best image quality, then you will not get the best results, because you want to have, of course, a functional evaluation, and you want to have consistent image quality. It, of course, comes at the price of a higher radiation dose. But remember, in this population, radiation dose is not our main issue, it's diagnosis. If a 90-year-old gets something from the CT scanner after 15 years of life, so he will be 105 years old, and I will personally apologize. But I would go for diagnosis over lower radiation.
Okay, Rodrigo, I have one more question from the chat. The question is, do you mention in your reports asymmetrical or eccentric AV cusp calcifications? If yes, in which cases?
We have we mentioned aortic valve calcifications, more descriptive. So we say, for example, there is no moderate, large, extensive calcifications. When we have extensive calcification at a particular point, we mention that because it's important for the deployment of your transcatheter aortic valve. We work with self-expandable valves, meaning that when you have extensive calcification, you can expect that the valve will not expand at a particular location to its maximum. But you have also to realize that the valve function of a transcatheter valve is just on a supraannular level. It's just above the annulus. So as long as your annular and supraannular expansion is okay, it doesn't matter that much if above that your valve does not expand very much, because your valvular function is at an annular level. What we also mention is the presence of subvalvular calcifications, because they may also inhibit proper deployment. They may push the transcatheter valve more upward on occasion, and especially in combination with a hypertrophic basal septum, this is certainly a risk factor for valve migration after the procedure and should be mentioned in the report.
Okay, any further questions? I'm just checking in the chat.
There is a very nice comment here in the chat from Mahmoud Abdel Shafi, referring to their own paper published this year in the Journal of Clinical Medicine. I just opened it with the title Predictors of Conduction Disturbances Requiring New Permanent Pacemaker Implantation Following the TAVI procedure, with the Evolute series, where several measurements and assessments were made, which were able to predict conduction disturbances after the procedure. including the membranous septum length, implantation depth, which is very interesting, which fits to the discussion that we had before.
Yes, we don't do that systematically.
Yeah.
And I think that maybe as we gain more knowledge and also the devices are becoming more and more sophisticated, I think that the TAVR protocol and the report will keep expanding with more and more parameters that can determine the prognosis and the procedural success.
Okay. So when there are no further questions, and I think this is the case, it's now 1:45, so we are perfect in time. I would like to thank all participants for being with us again for the first webinar 2024. Particular thanks, of course, to Rodrigo for his excellent, really
It is
fantastic.
my pleasure. My pleasure.
It was really a fantastic, didactically and also aesthetically wonderful presentation, as expected, by the way.
Thank you very much. You make me blush.
I know you. We can't see it here with the webcam.
Yeah, you're completely objective, I can tell.
Okay, so it was a pleasure to have you all here. We wish you a good continuation of your day, but we want also to highlight the next webinar, which will be at the beginning of February, 8th of February at 5 p.m. Central European Time, because we have as a guest Professor Wintersberger from the Department of Medical Imaging from the University of Toronto, talking about cardiotoxicity of immune checkpoint inhibitors, evidence from cardiac MRI, another very, very important and intriguing topic for cardiovascular imaging. Thanks to everybody.
Thank you.